Welcome to the SCI Forum podcast. This podcast was produced by the Northwest Regional Spinal Cord Injury System in the University of Washington Department of Rehabilitation Medicine. The Northwest Regional SCI system is dedicated to improving the lives of people with SCI through excellent patient care, research, and education. To learn more about our podcasts and videos or to make a donation, go to sci.washington.edu. This podcast was taken from a live SCI Forum presentation and may refer to images or visual information that helps to illustrate the spoken content. You can watch the video on our website or YouTube channel. Go to sci.washington.edu/videos.
Hello and welcome to the Spinal Cord Injury Forum. Tonight my name is Chuck Bombardi. I'm a rehabilitation psychologist in the Department of Rehabilitation Medicine. Tonight I'm going to be talking about resilience, depression, and bouncing back after spinal cord injury. And after my presentation, I'll open it up to take questions from the audience. All right, so why do we want to talk about depression, resilience, and bouncing back after spinal cord injury? I think it's really important for us to give people information who have sustained a spinal cord injury about maybe what to expect. Some of the good things to expect, like the fact that we'll talk about resilience is common. Some of the bad things to expect, that depression happens to some people. And also about things that can be done when depression does happen to people. How we can address depression and how we can help people bounce back. So I guess a big word that researchers use to describe good adjustment to spinal cord injury is the word resilience. So what's resilience? A positive adaptation to a major stressor. Bending but not breaking. I really like the word grit. And it's used in research and it's used in common language. That's why I like it. But it refers to people who are working toward goals, like trying to live a meaningful, happy, productive life, and doing that despite adversity or failure. And certainly people with spinal cord injury have faced adversity. It also refers to kind of flexible problem solving when things can be changed. And resilience refers also to accepting things when they can't be changed. Kind of like the 12-step prayer. There's the most popular measure of resilience is called the Connor-Davidson Resiliency Scale. It's got a bunch of items. I put 10 of them up here. But it's about, people saying that they are able to adapt to change. They can deal with whatever comes. They can see humor in things. They can cope with stress. And it strengthens them. They tend to bounce back, etc. Things like under pressure, they can really focus and think clearly. They can handle unpleasant feelings. So those are some of the terms that are used to kind of characterize resilience. Unfortunately, in a lot of the research, while resilience is a positive concept, a lot of the research defines resilience as the absence of a negative. That is, resilience is often described as not being depressed, not being anxious, not being, disabled by negative emotions. And so it's kind of a problem in how the research is done, and hopefully in the future we can conduct research that's more positively driven. But there has been a lot of research on resilience done in people who've sustained all kinds of different traumas, all kinds of different adverse events, all kinds of different losses. And George Bonanno was one of the main researchers in this field, and he studied lots of different, what he calls potentially traumatic events. And he's shown in a number of studies what are the different kind of common trajectories that people have in response to traumatic events. And so maybe starting from the top, you can see that there's kind of a small fraction of people that have chronic dysfunction, chronic problems, chronic emotional distress, about 5 to 30% in the studies that he's reviewed. There's also people who start off distressed, but their distress gets better over time. They're on quote-unquote a recovery trajectory. About 15 to 25% of people start depressed or distressed and then recover. A third group is people with delayed distress. And some studies find this group, some studies don't, but it's where people start off like they're doing pretty well, and then something happens later on and they get worse. They get more distressed, more depressed, more anxious over time. 0 to 15% in the studies that he reviewed have that trajectory. And then finally, the most common trajectory, and about 1/3 to 2/3 of people are in this trajectory after all kinds of different traumatic events, are quote-unquote in this resilient group. People who weather it without becoming depressed, significantly anxious, or disabled by their emotions. So you can see there's kind of different ways to characterize it, and I really like his work in that sense it shows kind of how people progress over time. So more on resilience, I really like to think of resilience not as a one-time event, but really a process over time, as that research describes. People get better, they can also get worse sometimes. The other thing is that people can learn to be resilient, and the military has invested millions and millions of dollars trying to train, for example, soldiers to become more resilient. Resilience doesn't mean not struggling. Resilience can include normal sadness and anxiety, normal fears. It can even include periods where people kind of give up. Resilience isn't where we start, it's where we end up. The good news about people with spinal cord injury is that most people who sustain spinal cord injury are resilient. The studies that define resilience as not being depressed or anxious show that about 1/2 to 2/3 of people with spinal cord injury are on a kind of a resilient trajectory. They're not depressed or significantly anxious. And then the one study that actually measured the positive attributes of resilience also found that about 2/3 of people with spinal cord injury were resilient over about a 1 or 2 year period. So that's kind of the good news. All right, so moving on to the not so good news. So depression happens after spinal cord injury. We have to talk about that as well. It happens to not the majority of people, but it happens to a significant minority of people. And this is just kind of a Venn diagram showing the different things that can happen. So obviously resilience is there, the largest circle, normal sadness, normal grief, normal anxiety, but not major depression, not anxiety, PTSD, or prolonged grief. So those are the other kind of circles, the other parts of the diagram, other pathways that people can be on in terms of adjusting to spinal cord injury. Major depression is the biggest one, and then anxiety and prolonged grief and PTSD are smaller, and they all kind of all overlap. So I'm going to spend most of the time tonight really talking about major depression. A little bit of time talking about grief, and I'm going to ignore anxiety and PTSD because there are other conditions, and of course they're present and we can deal with them, but they're not as prevalent as the other ones. So one of the myths I want to talk about when we start talking about depression is this idea that everybody has to become depressed. Of course I'm depressed, wouldn't you be? A common belief is that people after spinal cord injury get depressed, that everybody gets depressed. And just the idea goes that if I can't walk, I can never be happy, and therefore I'm depressed. And really what people do in this situation is kind of misattributing their initial emotional response, which is mostly grief, and calling it depression. Depression isn't really that intense feeling of shock and loss and sadness that comes in waves, after spinal cord injury. That's more grief. And there are common grief symptoms, and we're getting better at studying what grief is, normal grief and abnormal grief. But common grief symptoms that really cross over many types of different loss are things like intrusive thoughts, coming back to the injury or accident, longing or yearning for what happened, what life was like before, avoiding reminders. Everybody probably knows there are people who really have difficulty even looking at their paralyzed limbs. Bitterness over injury, feeling stunned or shocked or dazed, trouble accepting it as real, feeling emotionally numb. These are normal, common grief symptoms that people experience. As I said, there's more research done on grief, and this isn't research on people with spinal cord injury. It's on people who've lost a spouse. So I don't know how applicable it is, but I think it might help us. I hope we do studies like this in spinal cord injury. But you can see that normal grief after loss has these different trajectories. So down here you have yearning, right? So it starts kind of, I'm going to move over here for a second, but anyway, it kind of peaks and then declines. And you've got sadness, anger, disbelief, the kind of things we often think about in terms of grief processes. And then you also have acceptance. And this scale kind of indicates something really interesting, which is that we're kind of taught that acceptance kind of happens later, and it does. But isn't it interesting that acceptance is always higher than everything else? And acceptance is going on throughout the grieving process. I want to point out something about this slide too, which is that around at 6 months or so, you can see that the distressing kinds of affect the disbelief, the anger, the yearning, and so forth, they've kind of peaked by then, and they start getting better in most people. And that, I think, we don't know exactly how normal grief exactly, gets better over time, but it looks like more and more that after about, 6 months, 12 months or so, things are starting to get better in a person who's adapting well, and their grief symptoms are abating, and their acceptance is growing. So anyway, so that's kind of grief that goes beyond like 12 months or so, when symptoms remain very strong, when a person hasn't gotten back to anything in their life after a year. In people who've lost their spouses, scientists are beginning to consider that as something we should pay attention to and try to treat. We don't know whether that's true in people with spinal cord injury or other kinds of losses, but in bereavement, in people who lose their spouses, it might be. So that's kind of maybe research in the future. So I want to move on to what is depression. This is called the Patient Health Questionnaire. It's the most common depression screening measure that there is used out there. Maybe many of you may have filled it out in clinic. It's been given to me in clinic. It's made up of 9 symptoms, and the 9 symptoms exactly parallel what are the Diagnostic and Statistical Manual of Mental Disorders criteria for what's called major depression. So major depression is kind of an illness, and these are the 9 symptoms. In order to be diagnosed with major depression, you have to have one of the first 2 symptoms, either little interest or pleasure in doing things and feeling down, depressed, or hopeless. And you have to experience them more than half the day or nearly every day for at least 2 weeks. So the symptoms have to be persistent and almost every day. And then you have to have a total of 5 symptoms, and you've got these 7 other symptoms you could have. Sleep, energy, changes in appetite, feeling bad about yourself, trouble concentrating, speaking slowly or moving slowly, or the opposite, being fidgety or restless. And then thoughts of death or suicide are the symptoms. So having a total of 5 of those or more, and having at least one of the first 2, and having that happen for more than 2 weeks, at least 2 weeks, and also having it impair your daily life in some way, interfering with your functioning, that's really the definition of major depression. So the other thing I want to bring up about myths about depression is really who gets depressed. And I think there's a belief in our culture that only psychological weaklings get depressed. But, that's really not true, right? We know lots of famous people who would not be considered as weak, lots of actually famous athletes, Terry Bradshaw, Ricky Williams, who had struggled with depression. John Lennon, Ashley Judd, musicians who also struggle with depression. Lots of people get depressed. It's not about being weak. The other fact about this is that there's many potential causes of depression in people. So there's genetic load, right? Your parents, grandparents, your lineage may be prone to depression. Changes in brain chemistry cause people to be prone to depression. There's hormonal changes, inflammation. I didn't even mention some of the other things that we could mention in here. Even your brain structure, the size of your hippocampus matters in terms of whether you get depression or not. Also, environmental adversity, not only as an adult but as a child or later on. It can be things like income, loss of resources, parents dying, all kinds of things that cause adversity can be associated with depression, serious illness and injury. And then we should also pay attention to the fact that medications and illicit drugs can be associated with major depression. So I think one of the things I want to do in this talk is really to elicit everybody's help in trying to push back against this stigma of thinking about mental illness as something other than an illness and stigmatizing people who have it. There's been most people with spinal cord injury are male, and as a male, I know that I'll just say for myself anyway, it's harder to maybe deal with emotional issues, even as a psychologist, right? So, the National Institutes of Health has even come up with special programs to deal with depression in men, real depression. There's a whole website on videos of men talking about becoming depressed to try to help normalize it, right? And then this whole idea is of, thinking that depression isn't a real illness because, there's psychological parts to it. Well, you know what? There's psychological and behavioral parts to other diseases. How about cardiovascular disease? How about diabetes? You know, there's a biological part to those diseases, right? It's things that we can't control, but there's also behavioral parts to it too. My lifestyle makes a difference. So, you know, all diseases, or many diseases, have biological things we can't control, and then there's also lifestyle things that we can control, and depression is just like that too. I love this quote, "It's okay not to be okay." I think we have to kind of come around to the idea that, just like it's, like okay to have diabetes, it's okay to have cardiovascular disease, no one's going to blame you for that. It's okay to have depression. It shouldn't have the kind of stigma that it does. So how many people get depressed? So in the general population, about 2 to 4% of people are depressed at any one time. If you look in medical patients, primary care patients, about 5 to 10%. So, with medical illness, you get increasing levels of depression. When you look at people with chronic diseases like diabetes, coronary artery disease, stroke, MS, traumatic brain injury, you can see higher and higher rates of depression in these populations. So what are the rate of depression in people with spinal cord injury? So each of those bars, A through P, represent unique studies of rates of depression in people with spinal cord injury. So there's been a lot of studies, probably too many studies, looking at how common depression is. We need to do fewer studies on how common it is and more studies on how to make it better, right? So I've divided them into samples that look at inpatient rehabilitation versus people who are living in the community. As you can see, the rates of depression range from 20 to 38% in people during inpatient rehabilitation right after their injury, and then a little lower in people who are in the community, 11 to 31%. So I want to talk more about trajectories of depression, because I think that's really interesting. It's one thing to say, okay, a person's depressed at one point in time, but I want to know what's going to happen in the future. I want to know what it looks like over time. I think people want to know that. So a really cool study that was done in the UK. So in the European Union. So it involved the UK and also several European countries. About 250 people overall participated in the study with spinal cord injury. And then what they did is they looked at depression from the time a person first got in their wheelchair, right after their injury, until 2 years afterwards. And what they did is they measured depression at 3 months, 6 months, 1 year, a bunch of times. I think about 8 times in that first 2 years. And what they did is they basically put the graphs of each individual person on a big chart. What did their depression trajectory look like? And there's a program that can be used to kind of find out what are the common trajectories. Can they kind of cluster them together, see if there's some common patterns that people have? And what they found were these patterns. I put the red line in here because the red line is on the measure that they use of depression. That represents kind of clinically significant level of depression. So as you can see, kind of like in that original Bonanno study, looking at people who suffered other kinds of losses, you can see that there is a small percentage of people at the top, 12.5%, who pretty much have kind of chronic depression. It gets a little bit better over time, but they're in that depressed range throughout the 2-year period, starting early and also 2 years later. The next group is, again, a depression improvement or a depression recovery pattern, where you can see people started off almost at the clinically depressed range, about 12 or 11 on that scale, and then they improve over time. Significantly by 1 year, and then it's kind of flattened between 1 year and 2 years, but definitely improving over time. So there's a recovery curve. Next, there is a group, 12.8% of people who have delayed depression. So people who started off looking like they're doing okay, and then again, something happens, and they get more depressed over time. And we really don't know why right now, but it's something we should kind of pay attention to, find out why do those people become more depressed over time. And then just like in the literature on kind of one-time measures of resilience, here we have a different kind of resilience. This is a resilience that goes over time. And these are people, again, who are not depressed, not anxious, over a 2-year period, 50.8%, so almost 51% of people in that resilient category. So I actually had been wanting to do a study like this for years, and we had actually planned to do a study like this, and that other study got published before ours. This study is in press right now, but we did a very similar study here at the University of Washington, looking at trajectories in people with spinal cord injury. We had about 140 people here at Harborview and UW Medical Center. And we followed them only through 1 year. Their first assessment on the PHQ-9 depression measure was during inpatient rehabilitation. And we found 3 patterns, not 4 patterns. The first pattern, again, like other people have shown, is that on this measure, 10 or more, I'm sorry, the line's gone away, but 10 or more or 11 or more is considered significantly depressed. You can see this group, 7.1% of people who have moderate depression throughout that first year, pretty much at all time points, they're depressed, and it looks like they may be even be getting a little bit worse as time goes on. So, the other group, the second group, is the group in the middle, 29.1% of people who have mild depression. They're hovering around what's clinically significant depression, a little bit below, a little bit above. They're not getting better, they're not getting worse, they're kind of staying kind of in that middle range. And then again, as we've shown before, we have this huge group, the majority of people, almost 64% of people who are not depressed. They're not depressed in inpatient rehab, they're not depressed at 3, 6, 9, or 12 months. So throughout the time, they are remaining resilient. So both our study and the study that was done in Europe have kind of looked at what are some predictors of depression. And other studies have looked at predictors of depression. And one of the most important predictors of who gets depressed and who has a depressed trajectory, is pre-injury history depression. A person is 24 times more likely to become depressed than if they have a history of depression before they're injured, before they have a spinal cord injury, compared to those who don't have that history. So, I spent so much of my career thinking, gosh, spinal cord injury causes people to become depressed, only to find out in recent years that maybe depression, and the spinal cord injury are connected in some other way, and that people who end up having a spinal cord injury are pretty likely to have had a period of depression before in their life. And so it's not about trying to remedy this idea that spinal cord injury causes depression. It's just about treating depression that was there before, like we would treat other depression. Other risk factors are lower education and income. Obviously, people who have less means, more stress in their life, we know that's associated with depression in all kinds of populations. Pre-injury history of substance abuse, people who are less independent in doing their activities of daily living. Chronic pain is a big one. We'll talk about that later. And also some of these cognitive things I'm going to come back to in a few minutes. But how a person appraises their injury. Do they appraise having a spinal cord injury as a challenge? Or do they appraise their injury as a threat? We'll come back to this. Turns out to have a lot of predictive value. And that's studies done in the UK. Physical activity and exercise are predictors of depression. Higher activity and exercise is associated with lower depression. Sedentary, being sedentary, which is difficult not to be sedentary when you have a spinal cord injury, is associated with higher rates of depression. Also, coping style, and we'll come back to this as well. People who are characterized as having a fighting spirit, and I'll define these in a little bit and talk about them some more. Acceptance, those are associated with fighting spirit and acceptance are associated with lower rates of depression. Disengagement and social dependence are associated with higher rates of depression. We'll come back to these in a minute. It's interesting that study after study shows that spinal cord injury level, spinal cord injury severity are really unrelated to depression. So that's not one of the risk factors we want to look at. So I just want to kind of summarize where we're at so far before we move on to bouncing back. Is that, most people are resilient after spinal cord injury, and not becoming depressed is normal. Depression affects a lot of people after spinal cord injury, not the majority, but still a lot. In many cases, depression came before spinal cord injury, and depression has many causes, most of which are outside of our control. Some depression risk factors can be influenced, though, suggesting ways that we can help people bounce back from depression. I guess the main message I want to get across here is that depression is not our fault, not your fault, not anybody's fault, but we can do something about it. So in the next section, I want to just talk about many ways we can bounce back after spinal cord injury. So we've been interested in treating depression and trying to help with depression for a long time. One of the things we've tried to do is we tried to ask people who are depressed or have symptoms of depression, well, if you were depressed, what kinds of treatments would you want? If we're going to plan to do some kind of treatment studies, we should be asking people who have spinal cord injury, what kind of help would you want? So we've done that. It's interesting that 96% of people were willing to try some kind of treatment. So people wanted some help. 82% in a survey we did said they were willing to try an antidepressant. 80% said they were willing to try counseling, which was kind of a surprise to me as a psychologist. I often think, oh, maybe people don't want to do counseling. Well, yeah, people did. 74% of people said they would want to try some supervised exercise, physical exercise, if that would help. And then a lower percent would be willing to try group counseling, but almost half. We've done another study more recently. This one hasn't been published yet, but we were trying to look at the gaps between the treatments that doctors and nurses recommend, mostly doctors recommend, the ones people have tried, the ones people actually use, and the ones they're willing to try. And this all was done in our own clinics here at Harborview and University of Washington. So we asked people about antidepressants, treatments for depression. So we found that, basically providers recommend antidepressants in pretty much all the cases. Most people have tried antidepressants. A lot of people have stopped using antidepressants. They're not actually using their antidepressants, even though at the time we talked to them, they were depressed. So they're not on antidepressants. And a lot of people are still willing to try them. So there's a situation here where maybe a gap is between, yeah, I've tried antidepressants, I'm still depressed, I need to maybe try another one, perhaps. Right? So the next one is counseling and therapy. So again, lots of providers recommend counseling. Quite a few people have tried it. Very few people actually use it at the time they're depressed. But a lot of people are willing to try it. So there's a big gap between ever tried and willing to try, and a huge gap between actually using it and willing to try. So there's a lot of room to improve our delivery of counseling to people who are depressed and have spinal cord injury. And we've tried to do that actually by doing telephone counseling studies, to try to overcome some of the geographical and travel barriers. Then the last one is we asked about exercise. So we found that actually the gap here is really providers aren't recommending it very much as a possible treatment. And that's probably because we don't have great evidence so far that it's effective in people with spinal cord injury. We know from other studies in people who like older adults and other groups that exercise seems to help depression, but we don't know in people with spinal cord injury if exercise helps depression. We don't have good data on that yet. So that's probably why that's not recommended yet. Not many people have ever tried it. Not many people have actually used it, but wow, lots of people are willing to try that. Lots of people are saying, wow, if exercise can help me, physical exercise can help me, I'd be willing to give that a go. So that's what we know. We're trying to learn more about preferences and what people can do, and we'll continue to do that. So one of the things we've done, as I mentioned before, we've done so many studies on how common depression is, and there's been so little research done on, okay, what's going to help? And we've gone for decades. The first clinical practice guideline that kind of is like the guidebook for how to treat things in spinal cord injury was published back in 1998. And it looked at how to treat depression in people with spinal cord injury. And all the recommendations were based on people that didn't have spinal cord injury. There was no recommendations on people with spinal cord injury in terms of treatment. And here, this is, wow, 20 years later, we still, until this study was published in 2015, we still didn't have a single randomized controlled trial with a placebo group showing that some kind of treatment for depression worked. All right? So we studied venlafaxine extended release for major depression in people with spinal cord injury. We chose venlafaxine because we thought it was both a good antidepressant. We also had found out through kind of studying the different drugs available that it might have a good effect on neuropathic pain. And people know that neuropathic pain is really common in people with spinal cord injury. And we thought that it helps the kind of antidepressant it is. It's called a serotonin norepinephrine reuptake inhibitor. And that kind of antidepressant sometimes helps neuropathic pain in people with diabetes and other kinds of neuropathic pain. So we thought maybe it would help in this group too. So we had 6 different sites all over the United States, all recruiting for this study. A study that was also funded by NIDLR. We were ultimately able to randomize 133 people with spinal cord injury. They had to have major depression. Again, the 5 of those 9 symptoms, at least 2 of the first 2 symptoms. And they were randomly assigned to receive either the antidepressant venlafaxine XR or an inactive placebo. And what we did is we treated people for 12 weeks with increasing dosages of venlafaxine to what they were able to tolerate and what was effective for them. And then at 12 weeks, we measured depression severity using self-report scales of depression as also clinician-rated measures of depression severity. We measured other things like pain and self-reported disability and quality of life, things like that. We enrolled people between 18 and 64 years of age, people with all levels and severities of spinal cord injury. We enrolled people as early as 1 month after their injury and as late as 13 years after their spinal cord injury. And they all had to have at least moderately severe depression and met criteria for that major depressive disorder, those 5 symptoms, 5 of 9 symptoms. So here's what we found. When you do studies like this, you have to pick ahead of time what your primary outcome is, and we picked 2. One is called the Hamilton Depression Rating Scale 17. So it's 17 items. A clinician rates these items in an interview and rates how severe the person's depression is. And our first outcome that we predicted was that groups would be different in terms of the change in their Hamilton Depression Rating Scale score was. It didn't work. The Hamilton Depression Rating Scale, 17 items, a bunch of those items are physical items, somatic items, things like, I'm sorry, I'm blocking. But anyway, so it's fatigue, GI, upset, sleep, energy, other kind of physical symptoms that it turns out don't really change very much in response to antidepressant medications. Fortunately, we had another subscale of that 17-item measure, just a 6-item measure that we also use as an outcome, and it's called the Meyer subscale. And the Meyer subscale is used because it doesn't have all those somatic physical items in it. It has more kind of psychological items in it. And it turned out that on the Meyer, venlafaxine did do better than placebo. So people dropped 5.6% on the Meyer versus 4.8% in placebo. So they both dropped, right? And the statistically significantly more in the venlafaxine group. We also measure things called response rates. So the response rate is you're a responder if your depression severity drops by at least 50%. You're half as depressed at the end of the trial as before. So we measure that. So you can see that the response rate on the Meyer was 67% of people were at least had a drop of at least 50% in the venlafaxine condition versus 56% of the people in the placebo condition. So you can see that first of all, both groups are dropping quite a bit. So any kind of treatment, even if you get a sugar pill, it does help. I mean, getting help helps. Seeking help helps, and the antidepressant does a bit more. Here are the symptoms that are in the Meyer. So it's depressed mood, feelings of guilt, loss of interest or pleasure, feeling jittery or slowed down, or feeling or being slowed down. I'm sorry. And then feeling fidgety or jittery and anxiety. So those are the symptoms that venlafaxine helped. All right, so if you're depressed, have these symptoms, venlafaxine and probably other antidepressants may be helpful for you. We measured another thing. This is just a subjective thing, but we measured how people rated how disabled they were. How much does spinal cord injury disrupt their life? And it's called the Sheehan Disability Scale. And what we found was that in the venlafaxine group, people rated themselves as their subjective sense of disability dropped more in the treatment group than in the control group, in the placebo group. The Sheehan measures this. It says, my spinal cord injury has disrupted my work, school, or volunteer or rehabilitation activities. How much has it disrupted social life? How much has it disrupted family life and home responsibilities? So on that scale, basically people who had the venlafaxine said that they got better, that the spinal cord injury was disrupting their life less on venlafaxine at the end of the trial than the people who had the placebo. So it was an interesting kind of, effect, subjective disability. So So next I want to move kind of, away from medications to thinking, changing our thinking as a way to kind of get ourselves out of depression, to bounce back. So Henry Ford, said it many years ago, whether you think you can or you think you can't, you're right. He knew the power of thinking, positive thinking and negative thinking, right? Kind of self-fulfilling prophecy either way. So some researchers in the UK, Paul Kennedy and his group, have looked at how do people view spinal cord injury, especially soon after their injury. And they've kind of, as I mentioned before, they kind of divided up into two groups. People who view their spinal cord injury as a threat that they succumb to, or people who view spinal cord injury as a challenge that you can cope with. And it turns out that, so there's kind of like this kind of two roads you can go down. And it turns out that people do go down two roads. That early appraisals of spinal cord injury being a threat predicts people later who become more depressed and have poorer quality of life. On the other hand, people who soon after their injury judge their spinal cord injury to be kind of a challenge, something they can kind of cope with and work with, they have better quality of life and less depression. So this group of researchers have really tried to look at, how can we kind of help identify people's thinking style and maybe even treat it. They've even come up with a treatment called coping effectiveness therapy to try to help people kind of become aware of how they see things and change how they interpret and view things. So they've kind of identified several what I'll call thinking traps. So ways of viewing spinal cord injury that are not as helpful, and then trying to maybe switch it to something that's more helpful. So the first thinking trap I've already mentioned is this idea of viewing spinal cord injury as a threat. So, an example of that would be my body doesn't work anymore. It's like, this sucks. and people trying to change that to an alternative thought, which is that spinal cord injury is a challenge. I have so much to do to take care of myself. It's kind of more of a challenge type of thinking style. Another kind of trap they've identified is viewing oneself as dependent. I can't do anything for myself. And does it help? Can we help people change, or does it help to have a person view themselves as more interdependent with other people? I need to learn how to work with caregivers better. Might be that switch in your thinking may help with mood and depression. Another thinking trap is non-acceptance. So I can't accept that this has happened to me. And trying to change that to something that's more acceptance coping, which is, it is what it is. I can't, this sucks, but I have to deal with it. Another thinking trap that they've identified is that people kind of just giving up. They've identified disengagement or giving up as one thing that predicts poor outcomes. There's nothing I can do to change the situation, kind of a hopelessness. And they've identified an alternative, that is fighting spirit, as something that seems to really predict better outcomes. So I'm going to find ways to make my life easier or better. The person who's trying to find tricks, workarounds to try to make things better is a person who's going to do better. And can we help people do that? So, one of the main psychological therapies that's been used for years to treat depression, is effective in other populations outside of people with spinal cord injury, is cognitive behavior therapy. And the kind of cognitive therapy model is this, that there's some kind of activating event. Something happens. And then we interpret it. We have thoughts about it. And those thoughts have consequences. It have consequences in terms of our emotions, and also have a consequence in terms of our actions. And then our emotions and actions also drive the next round of thinking and so forth. So to give an example, is an activating event would be, the idea of going outside. Soon after your spinal cord injury, it's pretty challenging to go out. The thoughts might be, everyone's looking at me, all right? And the consequences could be anxiety or fear, and the actions would be avoidance. I'm not going outside, I'm staying in here. So in cognitive behavior therapy, we kind of look at again, thinking traps. What's the trap here? The thinking trap is me, me, me. It's like it's all about me, everybody's going to be looking at me, right? And what happens in cognitive behavior therapy, is trying to kind of change the thought, coming up, and people have to come up with thoughts that work for them. But is there an alternative thought that helps change the emotions and the actions? And so you've got this activating event going out. An alternative thought could be, it's not all about me. Strangers don't care what I look like or what I'm doing. I mean, people are minding their own business. It doesn't really matter. And the idea is that might change then your emotions. So maybe feel calmer, not so scrutinized, not like you're under a magnifying glass, not like you're a teenager again. And then actions, maybe being willing to try it rather than to avoid it. So in addition to trying to change thinking, another way to kind of bounce back after spinal cord injury and depression is really changing behavior. Changing activities or behavior is just as powerful as changing thinking in terms of, combating depression. Getting back to enjoyable or meaningful activities has strong antidepressant effects. So, there's the big things like returning to work, returning to like sports or things you enjoy, school, or trying new things you've ever done. It's just as important probably just to try to do something every day, some little thing that gives some amount of pleasure or some meaning to life. Scheduling those things in. Maybe it's the big things, but it's also the small daily things. A person would work with a therapist potentially doing something along these lines. So taking stock, what things have you done in the past that you've enjoyed or found meaningful would be something you could kind of oftentimes work with a therapist to kind of identify. And then we often have people do some self-monitoring, just kind of go through your week and pay attention to activities that are associated with feeling better or worse. Have people kind of self-monitor. And then the other thing we have people do that along these lines is to do personal experiments, which is, gosh, what would happen if you specifically plan to do that thing that you've kind of been avoiding doing or not done that gives your life a little bit more meaning, a little bit more pleasure? What would happen if you started scheduling those things into your life every week, a couple times a week? I wonder what would happen. So you do personal experiments. That's a way to kind of change behavior a little bit at a time. So the next kind of way to maybe bounce back is using physical activity. Physical inactivity. So there's been a physical inactivity is related to depression. Back in 2010, the last time a review study that I'm aware of was done was back in 2010. There were 15 studies then looking at physical activity and depression or exercise and depression. Together, they suggested that higher physical activity was related to lower depression scores. And that they pointed out how physical activity or exercise might improve depression through a lot of different pathways. One is just kind of a sense of accomplishment that people get from being physically active, a sense of confidence or self-worth that people get. Also, the kind of social part of some physical activity that's pleasant. But also there's biological changes. If you exercise more, your hippocampus grows. Your hippocampus is one of the parts of your brain that actually grows new cells in your brain. And that gets bigger when you exercise. And small hippocampus size is related to depression. Also, brain chemistry. Physical activity kind of helps generate chemicals in your brain, dopamine, norepinephrine, and so forth, that actually promote pleasure and recovery from depression. So you all know this, but I'll just say it because we're giving a talk on this. But there's lots of different ways to get physical activity. It's not all about going to the gym, although that's one option. And there's been one study, actually a randomized control study, that showed that when people did exercise in a kind of a gym type setting for 6 months, their depression was better than people who didn't. All right, their depression got better. But there's also other kinds of physical activity that people can do that doesn't involve going to a gym. So one is called leisure time physical activity, which is basically, wheeling for exercise or doing sports or even yard work, things you enjoy, playing with your kids, anything that gets you out there and becoming physically active, getting your heart rate up, sweating a little bit, whatever, just getting warmer, is good. And then there's what's called lifestyle physical activity, which is wheeling to necessary destinations, like parking away from, the grocery store or whatever, and really in the rest of the way. Any way you can kind of include more physical activity into your daily life, into your normal daily activities, is one way of increasing your physical activity. Another way I want to talk about in terms of bouncing back is trying to maybe improve pain control. We know how common pain is in people with spinal cord injury, and pain and depression really seem to kind of overlap. And there's been some studies that show that Depression doesn't kind of lead to pain. It's really the other way around. People who have pain, severe pain that's persistent, that seems to be a risk factor for people becoming depressed. So theoretically, treating pain might reduce depression. So I'm really interested. Diana Cardenas, who was the program director of this project before I was, is now in Florida. But she did a great study on pregabalin as a treatment for chronic neuropathic pain, and it's not very obvious in her paper, but if you look carefully, she also measured depression in that paper and found that not only did pregabalin improve neuropathic pain in people who got it compared to a placebo, but depression also improved significantly in the pregabalin group. Also, treating depression might improve pain. And so, as I mentioned, we had hoped, we'd chosen venlafaxine in our study to try to see if that drug would improve neuropathic pain, nerve pain. It turned out that it didn't. Nerve pain didn't change in people who got venlafaxine versus the placebo. But what we found is that when we looked at people who didn't have neuropathic pain, but they had other kind of pain, non-neuropathic pain, like musculoskeletal pain and so forth, those people actually got a lot better on venlafaxine compared to placebo in terms of their pain severity overall. So, in that study, we got people who were depressed better and their pain got better in response to venlafaxine. All right, so kind of to wrap up, I want to move toward maybe getting help for depression. So, if you are depressed or people you know are depressed, I want to encourage people to seek out help from their primary care physician, for example, or their rehabilitation physician, or people like me who are in rehabilitation departments who hopefully know something about spinal cord injury, or rehabilitation psychologists. Other primary mental health providers can also be helpful. Maybe they don't know much about rehabilitation or spinal cord injury, but they know a lot about depression, and they can be helpful. We know that it's a little bit more difficult to go seek help in mental health settings, but that's an option as well. And certainly we want to encourage people who have serious thoughts of death or suicide to please call 911 or a 24-hour national crisis hotline, which is 800-273-8255, or your local crisis clinic right away. If someone you care about is depressed, what do? Well, not surprisingly, people who are depressed aren't really that jazzed about seeking help a lot of times. They're not the best about reaching out and help. So there's really no one way to get them to reach out for help, or no one way to motivate them. But certainly we want to encourage people to ask how their loved ones are doing if you think they're depressed. Recognize that they're suffering and point that out. Communicate support and non-judgment, acceptance about how they're feeling, and encourage help seeking without telling them what to do. So to kind of summarize, I try to emphasize today that people are resilient. People with spinal cord injury and other people who've sustained losses are mostly resilient. People do well. But depression does happen to quite a few people. And there's multiple reasons why. It can go back to a person's childhood. It can go back to generations, to their genetic background. It can have to do with other types of adversity they've suffered. There are ways to predict who is going to be depressed, and the best predictor we have so far really is just simply, did the person ever get treated for depression before their injury, or were they ever diagnosed as having depression before their injury? Is a really good predictor of whether they're going to have depression after their injury. So there's many ways to bounce back from injury, and as I said before, depression is not anybody's fault, but there is something we can do about it. So I've tried to underscore there are multiple ways to bounce back. Antidepressant medications and venlafaxine or other antidepressants may really work for lots of people, and I encourage folks to consider that with your doctors. Counseling, changing thinking, behavior, or both can help with depression. And thinking of counseling is not like, more like coaching, having someone who you can talk with and can kind of be a support and a coach. Physical activity or exercise may be useful. Improving pain control might be useful. Getting counseling for anything thing that you think might be contributing to your feeling down or depressed. I mean, lots of things can contribute to being down or depressed. Relationships, other things can contribute. Getting help with any of those things may help. You're the expert in knowing what might be most useful there. And then when you have people who you care about who need a nudge to recognize the depression and seek help, please give them that nudge. All right, well, thank you for your attention. That's a really good question. So the question is whether or not there's been enough research on the potential side effects of commonly used medications in spinal cord injury and whether or not they may contribute to depression or not. And there is some research on that. So as you probably know, antispasticity medications sometimes can cause depression. Sometimes the anti-seizure medications may. I'm not a physician, but certainly side effects are an important thing to think about. We usually rely on people with, patients to rely on their report to say, listen, I started taking this medication. I think it's causing me to have this side effect, and to really get back to your physicians with that information, because some medications can, as you know, cause side effects in one person and not in another. So it's really you knowing your body, paying attention to your medications, and giving your doctor's feedback is really the way to go there. But it is probably something that needs more research. So the question is, does gender or age have an impact on depression? So we have studied that. I didn't mention that here, but women have higher rates of depression in general, and that is also true in people with spinal cord injury. And people don't know whether women have higher rates of depression or are more willing to report symptoms of depression. That's always been kind of a conflict in the field, right? The other thing about age is a really interesting thing. It turns out that there's kind of a generational effect of depression and age. So people who are kind of in their 60s to 70s and 80s now, that generation has low rates of depression compared to people who are like 18 to 30. And then also sometimes in some of our studies we've seen a high, kind of a blip of higher depression in people when they're injured, when they're in their like 30s and 40s, like when they're like right in the middle of their trying to get their lives, families, job, trying to launch, and if an injury happens at that time, sometimes that also is associated with a little bit higher depression. That's a little bit more speculative, but we've seen that sometimes.
Thank you for listening to the SCI Forum podcast. To learn more or to make a donation, please visit sci.washington.edu.